I try to connect. You're all welcome to this year's webinar. This is actually in continuation of the World Prematurity Day that was celebrated in November. We really wanted this to come up during that time, but we couldn't tidy up the whole arrangement. But we're glad that we're able to make it now, and then we're here. And this is actually to elicit our desire or our need, or for those that have our interest, for those that actually want to be in pediatrics, those that want to pursue a career in pediatrics. We want to ensure that we give you a good landing, so that you have premium information from the right personnel, from the right person, so that we can move forward and do the needful. So I welcome you once again. And then while we wait for others, we're just about how many here? So once we hit up to 100, we will just move. So call others to join, but we're not going to waste time. We're not going to keep our speaker waiting because she's here already. So welcome once again. You're welcome. On behalf of the chairman of the Education Committee, Professor Ogechi Zagu, I welcome you all once again. And on behalf of the National Executive, who gave an approval for this, the Professor Afam-led executive, we welcome all of you, and we wish that you would learn what we're trying to do, send out, and then we wish you the best in your practices, and then know that you can always reach out to us if you need us. So thank you and welcome once again. Please let us kindly mute our mics. Let us mute our mics. That's very important, so that we don't have distractions from the ground, and we don't have distractions from people around us, or our environment and all of that. So just mute a mic, and then we need to observe some form of ground rules. If you want to say something, you go to the icon of, I don't know if your phone or your laptop, and you raise your hand, you click raise your hand. And then once you click raise your hand, we would identify that, myself and the IT will identify that, and pick up your messages or your questions. So we want us to maintain decorum, we want us to maintain order, and then I believe that our guest speaker will answer our questions as much as we can, as much as she can. So basically, like I've said, if you're going to answer any question, the ground rules are like this. 1, mute your mic. Number 2, mute your videos, so that it's not a distraction for others, because I'm seeing some videos on. So mute your video, mute your mic, mute your video, as long as you're not the one presenting, please mute your mic and your videos. Number 2 is, if you want to speak, and of course there won't be any interruptions when the speaker is speaking. So when it is time for questions, we will take questions, and then we would you would only answer question by raising up your hand. So you're not expected to unmute your mic and just talk directly. So you raise your hands, and then if you also want, if you don't mind, you can also drop your questions in the chat box. The IT will pick it up, and then we would also present the questions. So we're supposed to have like 2 sections. The consultant pediatrician and neonatologist will speak to us, and after that we'll also have the didactic conversation concerning newborns and their preterm neonates and their nutrition. So we'll continue from where the consultant has spoken to us, and then we'll bring it down home to how we can understand and begin to implement them. All right, so without wasting much time, I mean, we've already waited so this is 12 past. So I don't want the consultant to think that we're not good timekeepers. So I want, please help me make welcome Dr. Mrs. Beatrice Ezenwa. She is going to be our guest speaker today. I mean, she's a wonderful person. She's a wonderful person, a wonderful doctor, I mean, it didn't take much to get her to make this presentation, and then it just happened. So she's just such a lovely soul, and then we really want to thank her. So on behalf of Education Committee, we thank you so very much. So Dr. Beatrice Ezenwa is an associate professor of pediatrics and a consultant neonatologist in the College of Medicine of the University of Lagos, and a honorary consultant to the Lagos University Teaching Hospital. Thank you so much for being here. Good evening, Dr. Ezenwa. Good to see you again.
Thank you very much. I'm actually blushing. I'm not sure you are talking about me. Thank you.
Talking about you.
Thank you.
Thank
Okay, so permit me to share my slide.
Yes.
Okay, so dear esteemed colleagues of the Dietitians Association of Nigeria, distinguished healthcare providers, doctors, nurses, and all stakeholders committed to the health of our nation's children, I say good evening once more. It is both a privilege and a profound responsibility to address you today on a subject that is at the very heart of neonatal survival and future potential. Every year in Nigeria, over 750,000 infants are born too soon. November is the month of prematurity, when we celebrate prematurity, and I just heard that this is supposed to be given at that time, and we are now doing it now. So it is still okay. These fragile beings, some of them even weighing less than 1 kg at birth, okay, they embark on their life's journey, not in the protected womb of the mother, but inside an incubator. So for decades, our primary triumph has been keeping them alive. We all can remember in the past in Nigeria, rarely do you hear that a baby born before 28 weeks survived. In short, up to now, Nigeria has not changed their age of viability. They still consider babies less than 28 weeks as non-viable in Nigeria. But we know that in many of our hospitals, babies who are lesser than that do survive. 25 weekers have gone home. Even 24 weekers have gone home sometimes. So that is no longer in doubt. Okay, we have mastered the pharmacology of antibiotics. A lot of them die because of infection, but we are now trying with antibiotics. And we've also mastered the technology of respiratory support devices. A lot of our hospitals have so many different devices now for their respiratory support. And the management fluids, we know that they lose a lot because of their large body surface. And all those things, we are mastering them. But today we are going to talk on a special one, okay? The survivor, okay? Is survival, is it enough? Is it that that we say that they are now surviving? Is that enough? It is time now to talk about what is the quality of that survival. And today, we are going to start with the most important one, okay? The preterm nutrition. So that is what we are going to talk about today. Let me put this thing in PowerPoint so that you can. Okay, so like she mentioned before, my name is Dr. Beatrice Ezenwa, Associate Professor of Neonatology with the Lagos University Teaching Hospital and University of Lagos. I do not have any financial disclosures to disclose at this lecture. So for this, our lecture, we are going to take it in the following outline. We are going to reframe the clinical paradigm. We've been talking about nutrition in the preterm, what is there before, and what are we finding out right now. We need to identify the 3 pillars of optimal care for the newborn. What are the 3 pillars that is going to help us? Analyze the context-specific challenges we have in Nigeria. Yes, we know that these newborns, they need nutrition. What challenges are we having in Nigeria? And then, of course, we have to make a commitment to take actions and help where we are. Okay, so to give a background on the preterm challenges in Nigeria, we know that in Nigeria, we account for a significant proportion of the world's preterm babies. Nigeria produces nearly 1 million preterm babies every year. It's a leading cause of our neonatal mortality. And right now, the neonatal mortality in Nigeria, instead of coming down, is actually going higher. Before, we used to be at 37 per 1,000 live births. By the last 2024 Nigerian demographic survey, we have gone up to 41 deaths per 1,000 live births. That is quite very high. If we look at the map that is in front, we see where the neonatal mortality is very high. And the leading cause of this neonatal mortality is actually the preterm mortality. So as we are looking at the neonatal mortalities, know that a lot of those neonatal mortalities, or more than 1/3 of them, are actually preterm mortality. And Nigeria is one of the countries, in short, we are about the second largest that is producing preterm babies, and we are also losing a lot of them. So I mentioned earlier that we are past mastering the we are overcoming some of our challenges before initially, because we don't have the facilities and the amenities, a lot of our babies are dying, but now a lot are surviving. Now we are getting new challenges. Okay, okay? So in as much as we know that survival is the first battle, the next one that we are now considering is that when these babies survive, what is the quality of survival? In our setting, optimal nutrition is not just medical care. Okay, it is a critical intervention that will also help us in national development. It helps to shape the future of our nation. If these babies, preterm babies that are born, if they're able to survive and have a good quality of survival, then they will have better cognitive ability and become very productive, and our nation is going to also thrive. So nowadays, it's not just about, okay, that baby survived, the baby went home. But what we talk about is, what is the quality of the survival? Is it the one that when they get home, for the next years, that child is going to be on earth, is going to be dependent on somebody? And one of the most critical things that helps these babies to have improved survival is nutrition. So for the preterm infants, nutrition is not just supportive care. It is the primary and foundational pharmacotherapy. So if we know that this nutrition, what we feed these babies, are actually like serves as drug for them, then we will do well to be able to help them to survive better, for them to thrive. Every meal of feed we give is a dose of make sure that this baby gets adequate nutrition from the first day of life. So a preterm baby is like a fetus, but instead of being inside the mother's womb, is now in outside. So most often they are in an incubator. So it's a fetus in an ex utero world, and the ex utero can be an incubator. Okay. So, and when these babies are born, because they are born immature, their physiological immaturity shows itself also in the gut. The gut is not well developed, so they have poor gut motility, and the enzymes that helps in digestion and all the metabolic activities of the body are also immature. Okay, the kidneys are not, there are also all the organs in the body are immature. And most of these babies are born at a time when development, especially the development of the brain, is at its highest. Okay, in the brain, 90% of the brain development occurs in the first 1,000 days of life. The 1,000 days starts from the day of conception until the child is about 36 months. Okay, in that time. So if this baby come out preterm, okay, they come out at a time that the brain is making a lot of undergoing a lot of high growth velocity, and so the brain consumes a lot of the energy that these babies need. Okay, at that time, so the energy the child is getting at a preterm baby is getting 60 to 70 of them percent of it is going for the brain development. Okay, so consequently, when these preterm babies are born, you find out that they need extremely high nutrient requirements, okay, per kilogram. So the smaller they are, the more they actually need high nutrient requirements, okay? And they are also the ones who doesn't have a capacity they don't have reserves. Okay, by the time a baby is born at term, they have stored a lot of nutrients. You see them developing fat, you see them, they have some fat. You see the babies when they're born, they're chubby, but preterm babies, you rarely see any, in short, they don't come out that chubby because they haven't had time to store any energy. And you know, energy is stored as fat. So you see the fat deposits in the babies. But for preterm babies, they don't have this luxury because they didn't stay long enough. Most of those nutrient stores are acquired during the third trimester, and a lot of these preterm babies are born before the third trimester, so they don't have the opportunity to store these nutrients. And then, so when they are born, one of the goals of nutritional care is to replace the in utero growth and nutrient accretion rates. So these babies, when you're feeding them, what you're thinking is in your mind is that you want to feed these babies so that they will get as much nutrient as if they are still inside the mother's womb. And I can assure you that this is a very difficult target to achieve, but it's achievable. Okay, so a healthy fetus, okay, or a healthy preterm baby, when you're feeding them, you're targeting to feed so that they will acquire the same uh, growth and nutrient accretion as if they are still inside the womb. And when you do that, okay, then these babies are going to have good development. But when you are not able to do that, then they will have what we call the extrauterine growth restriction. And what is this extrauterine growth restriction? It simply means that there is growth failure resulting in weight or length that is less than the 10th percentile at 36 weeks post-menstrual age, or when you are about to discharge the child. What this simply means is that at the time these babies are being discharged, or if they were born preterm, let's say they were born at 28 weeks or 29 or even earlier, and at the time they are 36 weeks, you measure them and you find out that their weight compared to the weight of a baby inside the womb at 36 weeks, you will find out that if their weight is below the 10th percentile, you know, we use growth charts. We use the intrauterine growth charts to measure the babies and then compare their weight with the standard, the reference standards. So at each gestational age, there is a particular weight that a child is supposed to have, and there is a particular length the baby is supposed to have. So for a baby, and these standards are usually measured with babies that are inside the womb. So if this baby who has been born before 10 is now measured, and then you find out that the baby, when you use the intrauterine growth chart, there are different types of charts. You can use the Lubchenco chart, you can use the WHO intergrowth chart for, they have also intrauterine growth chart for neonates. So some are, or the Fenton chart, which is used mainly for the preterm babies. When you measure the baby's weight or the length, and then you compare with this reference standard, if the baby is persistently below the 10th percentile, okay, on that chart, it means that that baby, because the baby is now not inside the womb, so it means that that baby has extrauterine growth restriction. Baby did not grow as expected outside the womb, okay? And this is a big challenge. And unfortunately in Nigeria, the prevalence of this condition is quite high in our different hospitals. And if often the clinicians overlook it, because, you know, when they said, when something becomes routine, it becomes normal. Okay, even when the thing is abnormal, because you are seeing it all the time, people now consider it as normal. In short, a lot of the facilities don't actually check if these babies are meeting up with what they are supposed to be at each particular time. So it's a dilemma that when you're managing these preterm babies and you start thinking about the quality of life they're going to have, you need to start thinking about it. These babies, are they getting optimal nutrition? Are they gaining weight as they are supposed to gain? Okay. Because if they are not getting the optimal nutrition as they are supposed to, there are some sequelae that is going to happen in future for them. For example, they may have neurodevelopmental impairments, okay, where these babies will have poor cognitive scores, they have motor delays, and you don't want to manage a preterm babies, and later when you see them, either they are not able to walk, they are being held when because they cannot sit, they cannot stand, and you that was enjoying that, oh, this baby went home, but it became a condition, I mean, a problem for the family. Okay, so when you're managing them, we are no longer excited with, oh, the baby survived. We want to be excited with the baby is thriving and baby is doing very well. And that is the goal now. There are other things that can also happen to that baby. So if the baby experience extrauterine growth restriction, they're also going to have to change their metabolic programming. Okay, and this is why some babies who came out very small, later on in adult life, they can become obese. They may have some metabolic challenges, like they can become hypertensive, they can have diabetes, because the programming has been changed later on. Okay, these babies also are prone to having weakened immune systems, and they cannot fight infections. Okay, I will know that most of the time when mothers come, you keep encouraging them to feed their babies. Okay, because when the babies are well fed, the likelihood that they can develop immunity increases and they can fight infections. So if the babies are not fed well, they won't be able to fight infection, and they have weakened immune system. So if we look at it, actually, this extrauterine growth restriction is largely iatrogenic. It means that we were not thinking about it. It means that we were not proactively trying to prevent it for that child. Okay, so, and it's something that is preventable with aggressive early nutrition. Okay, some people, when babies are born, they won't remember that the babies in the first hour of life, in with our Nigerian, what we teach now in Nigeria, within the first hour of life, a newborn must start feeding, and we must start feeding with breast milk. So when we don't have that aggressive nutrition, remember, preterm babies require more because they expend more energy than even the term babies. So if you don't feed them very early and you don't aggressively feed them and keep up with their nutrition, they are going to have this consequence of having extrauterine growth restriction. And we have what it takes to prevent this. Okay, what is that our greatest asset for preventing it? The breast milk. The human milk is called the liquid gold, and it's a standard of care everywhere in the world. Okay, so, and our own culture also promotes breastfeeding. So we don't have any problem or any challenge with getting breast milk. Okay, breastfeeding is deeply embedded in our traditions, and it is our first and most powerful tool to prevent this extrauterine growth restriction for these precious babies. So for the preterm baby, human milk is not just food, it is medicine. That first milk that the mother is producing, is giving to the baby in the first day of life, is liquid gold and is a precious medicine that we are giving to that baby. So it has a primary protection, and it's the strongest shield for that child. So when you are able to cancel the mother and you're able to get that milk, that initial milk, that first feeding, okay, the mother is very happy because she knows that, oh, I'm contributing to making my baby very healthy. So in preterm babies, we strive as much as possible to get that feed in the first few days of life. And it also prevents, when you're giving babies breast milk, it prevents a lot of things for them. For the preterm baby that are very prone to having what we call necrotizing enterocolitis, it's a condition, it's a complication of being born too soon. But giving breast milk reduces the chances. And of course, the breast milk you're giving also has other things it's providing for the baby. We know that breast milk is non-negotiable for our babies. It is exceptionally so for the preterm babies. It is a pharmacologic intervention. Even if it's just one drop of breast milk that you are getting from that mother, since all this baby will need, okay, most of what that baby needs at that point in time, it contains it. It's a drug we are giving to this baby, even if it's one drop that comes. And we know that beyond nutrition, the breast milk also do other things for the baby. For example, it improves the immunoprotection in that baby because it contains secretory IgA, lactoferrin, and lysozymes. These are things that help us to fight infection. And it promotes gut maturation. It reduces the risk of necrotizing enterocolitis, like I mentioned before. Necrotizing enterocolitis in preterm babies is a complication of being born too soon. Also, the breast milk also helps in neurodevelopment. The breast milk contains some long-chain polyunsaturated fatty acid. It contains human milk oligosaccharides, okay, the HMOs. And these are factors that the brain needs for their development, and it's very abundant in breast milk. So when we are giving the baby, this preterm infant, the breast milk, we are promoting all these for good development for that child. So what is our duty? Our duty is to create a mother-centered lactation ecosystem in our hospitals. We have to have a way of bringing the mothers to participate in the care of these babies. If they know that they are part of the team managing their baby, they will be more cooperative and they will bring this breast milk. Every mother of a preterm must be made to be aware that she is part of the team managing her child, okay? And her milk is the primary prescription, the primary drug, because the breast milk is a drug that we are giving to this child. And we know that when we give the breast milk, it protects the child against so many things. It's giving the child energy, it's protecting the immune system, it's helping the baby to develop both the brain development and the development of the other organs of the body. So, but we have a critical challenge. We know that in as much as the breast milk is a gold standard, it has some limitations when it comes to the preterm baby. It is the perfect food for the preterm baby, but it's incomplete to meet the preterm baby's needs. So this is a paradox. We have a perfect food for the term baby, but for the preterm baby, this perfect food is not complete for the preterm, for the singular reason that preterm babies, they have a higher, they need higher nutrient needs compared to that of a term baby. So while human milk is perfect for term babies, the preterm baby born at less than 28 weeks or less than 32 weeks has nutrient needs that are 2 to 4 times higher than that of a term baby. And then we usually measure their needs per kilogram. So the baby that is 2 kg has compared to a baby who is 1 kg. So their nutrient requirement is usually higher than that of a term baby. And to compound it, these preterm babies doesn't have any nutrient reserves, unlike the term baby that already had some reserves because they stayed long enough to acquire some of these nutrients from the mother before they come out. In the preterm baby, they didn't have that luxury. They didn't stay long. So, and when they come out, because they came out at a time when the body is developing very, very fast, okay, their nutrient needs are extremely higher, very high compared to that of a term baby. And when you give them breast milk, as it is, usually not enough for them. So what do? We now know that there is a gap. The human milk alone cannot provide enough protein for the preterm baby. It doesn't contain enough calcium, phosphorus, and energy for them to grow a brain and also the body. If we are going to use the in utero growth to measure their own growth, they are not going to meet up with a baby who is inside the womb, okay? So because we know this gap, what have we been doing about it? Okay, that's where fortification of breast milk comes in. So what do we do to the golds? Our breast milk is the gold, but we now need to fortify it for the preterm babies. Okay, so we know that the problem is, we know that if we don't fortify that breast milk, it will not be able to, it doesn't contain enough protein and calorie for the preterm infants. Okay, so we now fortify it with human milk fortifiers so that it can increase the protein content, the calorie content, and the mineral needs of the low birth weight infants. So when we are talking about fortification of breast milk, what are we actually concentrating on? There are some nutrients that we actually concentrate on when we are making fortification of the breast milk. Remember, we said the breast milk is a gold standard, is the perfect food, especially for the term baby. But for the preterm baby, we know that some of the things, because of the rate they're increasing, their body is growing, okay, they need higher protein, and the milk content of the breast milk is not enough for that preterm baby at that time. So most of the time when we are fortifying, we consider the protein. We want to give the protein content of the baby's food to reach 3.5 to 4.5 grams per kg per day. Okay, the breast milk doesn't have up to this amount of protein in its content. We also need to improve the calcium content of the breast milk, and that's why we give the babies calcium and phosphorus. And this helps to prevent the metabolic bone disease of prematurity, which is a disease that that preterm babies can have because of low calcium that they don't calcium reserves they have. Okay. Also, energy and micronutrients can also they can be fortified. If you come to the newborn unit most of the time, you see that these nutrients are actually being provided. You see us giving them Abidec. You see them also giving them multivite. You see us giving them calcium and phosphorus. And they take this, and you see us giving them iron, because we know some of these micronutrients are not sufficient in the breast milk. And these babies didn't stay long to acquire some of them, even while in utero. They don't have enough energy too. So sometimes we also supplement the breast milk with some some fortifiers to help the energy and the energy content and the protein content of the breast milk. So what is our role as we are to champion human milk and be the experts in safely enhancing it? That we know that there is a gap does not mean that you will now throw it open to everybody. We know there is a gap. We don't want postnatal failure. So mothers, go and be supplementing your baby's food because their breast milk is not enough. It's not true. Okay, breast milk is still the standard, but we know that there are some things that these babies need. So we need to know how to, we have to safely also enhance it. We don't just throw it open there. Or yeah, just give your child anything you want. We need to moderate it. We need to know exactly what it is that we want to give to this child. Okay, so it's not all babies. I have had calls for some of my patients to come to the clinic. They tell me, doctor, this patient that was in the ward with me, I see that the babies are giving some drugs when they're going home. Why didn't they give my baby the same drugs? And I had to sit down to explain to them that baby that they were giving some of those drugs, some of them they will go home on iron, they will go home on calcium and IB. They did not give to her child, because your child is a term baby and has all this. As long as you're eating and the child is breastfeeding, she's going to get enough, okay, until 6 months. But for these other preterm babies, we know that they cannot get enough. Okay, what they require and what their mother is producing will not be enough to meet up with the baby's requirement. And that is why in them extra, those supplements to have a safe way of managing them, that you know that this is what is happening, and you can be able to tell them, okay, this is what you do, this is what you do not do. It's not all babies that require breast milk fortification. So let's go back again to that breast milk. We know that when babies are born, the mothers produce the first milk, which is the colostrum. And the colostrum has been called the liquid gold because it can improve, it also have immune therapy for that baby. So even if it's just one drop of colostrum, one drop of milk that comes from that mother from the first day of life, okay, it is liquid gold that we are giving that child. Okay, so in the first days, when full feeds are not possible, oral colostrum care is vital. Because some mothers, when they try, lots of the preterm babies cannot suck direct on the mother's breast, so the mother has to express. So that is another challenge for them. For them to now to express and for you to give it to these babies, okay, even if, so they will express and they say nothing is coming out, and they said only one drop, and somebody will go and throw away and clean it off. No, even that one drop that comes out will go a long way. Sometimes just using your finger or your gloved finger to take it and rub it on the baby's mouth is all that is taken for that time. And then the mother try again and keep on expressing. So applying drops to the infant's mouth provides immune factors that line the gut and fight infection. That one drop, that single drop that the mother was able to produce, it goes a long way. So please, they shouldn't throw it away. They shouldn't clean it off and say that nothing is coming. Something is coming. That one drop. Please use it and do an oral care for the baby. And then continue to encourage the mother so that mother continue expressing and bringing out whatever it is. However, one drop, 1 meal, 2 meals, whatever. Let the mother bring it and let's give to the baby. So collect this and administer the colostrum from the very first expression, from the very first day of life. And this is low cost. It doesn't cost the mother anything. The only thing it costs is that somebody has to come and help her, because usually when they deliver, a lot of them may not be exhausted. They won't be able to express that. But if somebody is there supporting them, they may be able to do that. And it is by the time the mother also understands that she too is part of the team managing that child, and that this is the problem the child have, and we need to, that her breast milk is one of the drugs we need to give to this child, the mother will try more. You need to teach the mothers that their first milk is like the first vaccine for the baby's gut. It's going to help the gut to mature. It's going to help the child to fight infections and all that. The mother will be more willing and they will strive harder to produce that first milk. So the first, usually they don't produce enough for the child in the first few days. So we can give them what we call the trophic feeds. Just 0.5 meals to 1 meal of per kg per hour is enough within the first 24 to 48 hours of life. And what this does is not nutritional, but it helps to prime the gut, to tell that gut that, oh, something is coming, that this child will soon start feeding, okay? And then you start feeding them gradually, cautiously, okay? And your aim is that by the time they are being discharged, that they have gotten their weight gain has equaled their weight gain if they were still inside the womb. Okay, not that because now they are outside the womb, they are no longer gaining weight, they are losing weight because of extrauterine growth restriction. We don't want that to happen. We aim that by the time the babies are about 10 to 14 days, they should have regained their birth weight and then start gaining weight. Most of the time, because we know the challenge that these mothers will not produce enough milk in the first few days, we usually start them on parenteral nutrition. And in the parenteral nutrition is just to bridge the gap until the mother is able to produce enough nutrients. We don't have there is full parenteral nutrition, in which case we are giving, including, we are giving the child all the nutrients parenterally, both the fat, the protein, the calorie, all of them are going. We are giving the child parenterally. But in our environment, most often, what we do is to give the calorie, and that is what we do with the dextrose. And then by the time we are adding the amino acids, like the aminoven or the trophamine, we are now adding protein to it. Okay, for the lipids, a lot of centers in Nigeria, in short, almost all the centers in Nigeria are not doing lipid parenteral nutrition because of its challenges, and we don't have the capacity. We've not been producing it in the country. Okay, there are also some countries who even the dextrose they cannot produce. So it's not only us, but we can get more of that, even to get a complete parenteral nutrition. It's not common, but there are some places that can be able to afford it and able to procure it, but it's not readily available, especially the lipid parenteral nutrition in Nigeria for children, not for adults. Because what we see most often, like the amino acids, is the adult one. The histamine is not for, and it's not meant for newborns, but that is what we see most of the time. So instead of getting trophamine or aminoven, you see us using the amino acid histamine, and that is for adults. It's not for for babies and we run away from it because it causes problem for our babies sometimes. So for you, you need to keep on monitoring these babies that are growing as expected. So weekly weight gain, in short, for preterm babies is usually daily weight gain, but because we know that they are supposed to be gaining weight every day. Once they, by the 10 to the 14 days, we expect them to have regained their birth weight and then start gaining. We expect them to gain 15 to 20 grams per kg per day. Okay, so if they are not gaining it, then you know that the nutrition is not optimal, that something is happening. You need to go back again and look at them. Weekly OFC monitoring, because they should be gaining the OFC has to be increasing at a particular rate every week. And you also need to be checking their electrolytes. Bicarbonate is very, very important because when the bicarbonate is very low, they may not be able to gain weight. So you see us checking their electrolytes on and off to be sure that everything is checking out. So when we talk about fortification in our setting, we've had some practical fortification methods. So we start from the basic to the advanced. So for our unit, when we talk about fortification, we first ask for the human milk fortifiers. The human milk fortifiers are ideal. And if the parents can be able to procure them, okay, then we use them when they are available. They are usually quality bovine-based fortifiers. So they are produced, are marketed, and people buy them. We use them a lot in my unit, but it's very, very scarce. Sometimes you prescribe it and the mothers will not be able to get it. In short, to even get it in the country is very difficult because it's not I don't think any company has been able to get NAFDAC number and is importing it. No, I don't know of any company. So you find that it's very difficult to get it. So those who get it in small quantities, and then it finishes again, and you will be looking for how to get another one. Okay, so the human milk fortifiers sometimes there are different types. Some of them contain multi-nutrients that you can add to the breast milk and increase either the calorie content or the protein content, or sometimes the micronutrient content, depending on the type you have. And these can actually make a lot of difference to that breast milk. But because we don't have a lot of human milk fortifier readily available, the modular approach is another one. So this is the second option that we do go to. So when commercial human milk fortifier is unavailable, we can strategically supplement with carefully. We can add the protein, just like we add something. We can use the hydrolyzed protein powder. This one we don't have, but the some of the formula can be used for it. We also have the one that we use sometimes oil, and my own center, we use it sometimes, the medium chain triglyceride oil, or use the glucose polymers. And for you to use that strict, babies come out with them and all that. And of course, for minerals, we usually add fortify with that. We put our babies most of the time on calcium. You see us giving from the first day of life, the hello, where did I lose you? Sorry, where did you lose me on this slide?
Yes, ma.
Yes, ma, that's where we are, ma. We've not reached this particular slide.
Okay, here.
Yes, ma.
Okay. So I was talking about the second approach that we employ when we add medium chain triglycerides oil. Okay, and this is usually, I think medium chain triglyceride can be gotten from coconut oil, or our dietitians have been the one helping us with this. For minerals like calcium, phosphate, and co, we can also fortify by giving these babies these supplements. So most of the time in our units, you see us giving these babies calcium even from the first day of life. Then you supplement with some nutrients, vitamin D, some multivites, and all that. So this is to make the breast milk that are getting richer. Okay, the third tier is the targeted fortification. When you're doing targeted fortification, it means that you are actually, you've tested or you've taken the mother's breast milk and tested it, and you have discovered the nutrients that are deficient in that breast milk. And then those nutrients that are deficient is what you're actually supplementing the child with. So where you do targeted fortification, you measure the actual content of the mother's milk and fortify precisely. And what this does is to eliminate guesswork, because you won't be saying missing, or is it the protein that is low? So you know which exactly you are trying to fortify, and then you go directly and fortify that. This eliminates waste, and of course reduces the time to achieving what you want, and eliminates guesswork. More cost effective if you can be able to analyze the human milk that you're giving that baby, the mother's milk. So all mothers, I haven't come across any paper that have analyzed breast milks in Nigeria. Something to look at. All the ones we've been hearing and seeing are analyzed elsewhere. Okay, some of our, we are looking forward to one day somebody will come and say that, for mothers in Lagos, mothers in this place, that this is the breast milk content. Do they match what we hear, what we see abroad? It will really be an eye opener. So to get our breast milk and to ensure quality nutrition for our preterm babies, we know that we have some challenges and bottlenecks. And some of these challenges can be systemic. For example, you want to give breast milk, and the mother is somewhere else. Many a time, these babies are in the NICU and the mother is elsewhere. Okay, in as much as we are trying to change that, but sometimes the mother has to be away. So if the mother is not going to be available for this express breast milk, can she express it and you keep it? You find out that you may not be able to keep this because you don't have refrigerator. There is no power to power your refrigeration. So you won't be able to keep it. The mother is there all the time to be expressing. Mother cannot rest. Then you cause another problem for the mother because the mother is not resting. Okay. Inconsistent water supply. You can't even maintain hygiene, okay, for that baby because there is no water. Okay. Infection control is also a problem. So some of these may be challenges that you're going to face in your unit to maintain proper nutrition. I mentioned before that you rarely do lipid parenteral nutrition in Nigeria. It's because of infection. Okay, you need to be very, very have very superb infection control procedures in both making it and in preparing it. Okay, some people that have tried come down with a barrage of infections and then outbreaks of infection in the units, and they have to close again because so until we're able to master that, it's usually a challenge. The another challenge may be that of resource availability. Usually, our human milk fortifiers are scarce, and when they're available, the cost is very prohibitive. So we don't have it. Even parenteral nutrition, to get it is very costly. Like the lipid parenteral nutrition is quite costly in as much as it's not readily available. But when you see it, it's very costly. Even some, for those babies who may require formula or the other, formula too is not chicken change. It's also very expensive, especially the very high quality ones. And we don't have donor milks in Nigeria. A lot of people have started, and then I've heard of donor milk banks in several places in Lagos, but we are not yet sure if they are actually existing. And if they're existing, what is the quality? Are they really, I mean, nobody has come out to say this is the milk bank or that is working, but once in a while you hear somebody say they got breast milk. So what we have been using is to surrogacy. Those who are breastfeeding, if somebody in your family is breastfeeding, you may be able to they may give you breast milk for your baby, or you can get somebody who is breastfeeding as they're breastfeeding their baby to also give you baby. So we've been getting some of those as donor milks here, but for a donor milk bank, okay, that is publicly available, it's not, we haven't seen that. Also, knowledge and practice gap is also challenges. When you go to a lot of hospitals, they have different protocols, how they manage preterm babies in their units. So sometimes a lot of people under prioritize the nutrition aspect. So the baby is going home. The baby who is supposed to have regained their weight is below the 10% and they are sending the baby home. Sometimes they don't even know that there is a problem. Then sociocultural. Sometimes the maternal nutrition is also not very good because of poverty. We know that when the mother eats well, has balanced diet, the milk will also improve. Sometimes the mother is under stress. And sometimes, I'm very sorry, please give me a minute. I have some issues. I'm coming. I need to follow.
All right, hello everyone. You will agree with me that this is this has been quite engaging. You know, some of the things that we think that don't matter, we're beginning to see that they are so important. And then, of course, we know that this is a whole circle from pre-time to new to term babies, then they become preschool, toddlers, they become toddlers, preschool, and all of that. The circle goes on. So we need to realize that prioritizing these small warriors is, very key for us, because we dietitians are great. Dietitians are, when our presence is non-negotiable, you will agree with me. And sincerely, it is how much we bring ourselves out there that will determine who we are. So she's back. We'll quick continue. Welcome back,
Yes,
Dr.
I'm so sorry. I haven't been feeling fine, so they had to go and, sorry, I'm very sorry for that interruption. So as I was saying before, where were we? Okay, we were at the challenges and bottlenecks. I was at number 4. I said that sociocultural maternal nutrition may be compromised because of poverty. And when the nutrition is not optimal, okay, the breast milk also that the baby is getting may also be affected. If the mother is under too much stress also, she may not be able to produce enough breast milk. We also need to have sustained lactation support. And what happens is that once a mother delivers, we all expect that that mother will have known how to express, how to breastfeed, and people don't remember that they may need to support this new mother, to train her on how to breastfeed, encourage her in producing this breast milk. And sometimes you find out that in our hospitals, the early discharge is babies are being discharged early because of pressure for space. They want more new babies to come in. And so because of that, a child that is still not ready to go home, or a child whose mother is not yet confident in breastfeeding, is sent home prematurely. And then when they get home, the mother will now be struggling. And next time you see the child in clinic, the child has lost like 1 kg of their weight before they left. Okay, because somebody has not taken the time to explain very well and be able to tell the mother how to breastfeed, what to breastfeed, how often to breastfeed, and how to be breastfeeding the child. Sometimes also cultural belief is another problem that we encounter. For example, I know in some places, they say that the colostrum, that is a dirty milk, that when the mother produces colostrum, they should throw it away, okay? Because they do not know what to, what is good for that baby. They will throw away the colostrum, waiting for the normal milk to start flowing before they breastfeed their child, forgetting that the colostrum contains things that are different from the matured milk and are depriving the baby. So some of these beliefs, when we come across them, we can be able to explain very well and tell them why it's important that they give this baby the colostrum. I also know that there are some mothers, if they have cause to go somewhere and they didn't go with their baby, they come back the next day or so, and somebody will tell them that because you have missed breastfeeding for 1 day or 2 days or 1 week, you can no longer breastfeed. Okay, so those are some beliefs that we need to encounter sometimes and be able to debunk some of those myths. Our role is to be system builders and culture navigators. So if we find some of those things that are causing challenges, we can be able to navigate around it, be able to explain them, be able to find solutions, find ways to overcome some of those obstacles. Okay, for all the time, at all times, we have to be advocating for accessible, affordable human milk fortifiers. I don't miss opportunity. Anytime I see some of these people who can be able to bring it in, to tell them to please look at it, or is there any way anybody can bring these human milk fortifiers, because it helps us. If you manage preterm babies, you will be looking for human milk fortifiers all the time. Okay, and then we are also seriously looking forward to starting a human milk banking in Nigeria. And any support that we can get, or wherever we can be, whoever is going to help us develop one and start one in Nigeria, I'm sure the person is going to get very good support from all the people who are managing preterm babies in Nigeria. So there is something that we cannot finish talking about in prematurity without talking about it, and that is the kangaroo mother care, because kangaroo mother care is taken as nutrition support. It's an adjuvant to nutrition. You cannot finish talking about nutrition in the preterm babies without mentioning skin to skin. That is the kangaroo mother care. Okay, it's an ultimate feeding adjuvant, because if a baby is in kangaroo position, you are sure that baby is very close to the breast. So breastfeeding is improved. breastfeeding is supported. So kangaroo mother care is metabolic support. It stabilizes the heart. So these are some of the benefits of kangaroo. A lot of research has gone into it, and all over the world, people are talking about kangaroo mother care. In short, a lot of people, a lot of facilities, even those who have incubators, they no longer put babies inside the incubator, because it has been found out that when they do kangaroo mother care, it improves so many things. It's not just the nutrition, even the brain development is improved. It has so many other support for the baby that is makes it even superior. There is actually a study that was done by WHO in which Nigeria participated, and that was in 2020, 2021. They published around 2022. And they found out that they did kangaroo mother care for babies who are 1,000 grams and above, between 1,000 grams and 1,500 grams. These are preterm babies. And they found out that babies who were nursed in kangaroo mother care position compared to those who are nursed in incubator when they're born, that those that they did kangaroo mother care survive better than those who were nursed inside incubators. And WHO has to stop that study midway because the evidence was overwhelming that those who were doing KMC, that they had better chances. I mean, that they thrive better than those who were nursed in the incubator, okay? In terms of mortality, those in the incubator died more than those who are. In terms of breastfeeding, those who are doing KMC get better, I mean, weight gain compared to those who are inside the incubator. So WHO didn't allow that study to progress and complete. Okay, they stopped it halfway. We've known now that kangaroo mother care has metabolic support for the baby. It stabilizes the baby's heart. It stabilizes the breathing and the temperature and reduces the infant's calorie expenditure on staying warm. So the mother's warmth keeps the baby warm, and it doesn't, so the baby is not burning energy trying to keep itself warm. You know, preterm babies cannot maintain their body heat. If you leave them outside, they won't be able to, they will be struggling. They will be using all the energy they have to maintain temperature. So if the mother is doing the KMC, then that struggle will be reduced and they can use their energy to grow instead of trying to maintain their body temperature. Kangaroo mother care boosts milk production also. So if the baby is close to the mother, the proximity and the smell of the baby increases the prolactin letdown and the oxytocin. And then the mother will produce more milk, okay? It also empowers the families. Fathers and grandmothers can be involved. In short, in my unit, sometimes when you come, you see the grandmother doing the KMC, you see the father doing KMC. So everybody, aunties are also doing KMC. So anybody can do KMC. Once they're dedicated and you have chosen this is the person to do the KMC, they will do. So they will help. It brings the family together. It helps the father, it helps the mother, even the grandparents can be able to also help. And of course, it improves the bonding in the family. It transforms the narrative for the family from one of passive waiting to one of active healing. They are there. They know that they are doing. There is one grandmother that is doing KMC for one of our babies. And whenever you come, she's the first one to come there. When the others are not, she said, no, this is my grandchild. I'm here. And she will be there. She's there all the time. We will be begging her to go and rest. She said no, that she wants to do this kangaroo mother care, that she's very happy doing it. So it makes them bond very well with the baby. So now in every NICU, we must be KMC champions, and we must ensure that we are promoting it in our hospitals. And I think because it helps in nutrition, because if the baby is very close by, the mother will produce more breast milk. Our nutritionists and dietitians should be one of his strongest advocates. This kangaroo mother care thing. Every hand should be on deck to promote it because it helps in so many different ways. So there is a call to collaborative action. It's not just one person doing it alone. All of us should be doing it together. So what can we do together? For doctors, nurses, the clinicians, we need to adopt and audit standardized feeding protocols. If we know that we need these babies, we need early and aggressive nutrition, then we start from the first day of life and then have a protocol that ensures that we start feeding them from the first day. I know that in the past, when preterm babies are born, they say, no, leave them or raise their guts until they are 48 hours before you start. But now, research has shown that you start feeding them from the first day. Nigerian guidelines says within the first 1 hour of birth, the baby must start feeding breast milk from the first 1 hour of birth. So we must champion maternal lactation support. If there is any way we can help the mothers to produce breast milk, and this usually starts even from antenatal, supporting them, encouraging them, telling them about it, so that when they deliver, they know that it's not something strange, that they will be able to produce milk for their baby. So we all need to champion maternal lactation support. For our nutritionists, we need more research locally, especially cost-effective fortification strategies. Analyze nutrient composition of Nigerian maternal diets and milk. Which one can improve breastfeeding? What do they eat and their milk will be richer? Okay, is that something we can do? I know that in my facility, our dietitian has been in the forefront, helping us in doing the medium chain triglycerides. Okay, and I'm sure that in other facilities, we've been coming together to find ways of trying to help our babies to thrive. Okay. For the hospital administrators, we need to invest in lactation consultants. And I need to tell you this story. In my unit, that was last year or so, in my unit, we got this, some of our doctors, we are doing a research on something, but we got 1 or 2 doctors then to help us with lactation managing. So babies who are delivered, they follow up with their mothers and then they support them, they counsel them, and then they show them how to breastfeed or express. And at that time that they were available, our breastfeeding rates shoot up. All the mothers, they were producing breast milk, first day of life. What they said was difficult, impossible before. We started getting breast milk. Even few hours, first hour after birth, we are getting express breast milk. Babies are now, they become so indispensable that when the project finished and they left, we were like, what are we going to do? So it is very, very possible if we have to invest in lactation consultants, lactation managers. This will help mothers to encourage them to express. We can also have milk expression rooms, have pumps, breast milk pumps that they can be used. They have these hospital-grade pumps that can be used for breast milk pumping. But what we find is that in most hospitals, in my center included, we don't have breast milk pump. All mothers have to hand express. Okay, and then refrigeration and training. Sometimes they express the milk is much and there is no way to store it because there is no refrigeration or there is no light. Okay, so those are some challenges that the hospital management can help to overcome. For policymakers like the Ministry of Health, Federal Ministry of Health, prioritizing funding for breast milk bank is something we can do, how to get more parenteral nutrition. Like I said, in Nigeria, we don't have that lipid parenteral nutrition. Establish national guidelines and donor milk bank pilot projects. For the national guidelines, I can assure you that the Federal Ministry of Health, in collaboration with the Nigerian Society of Neonatal Medicine, actually have a comprehensive newborn guidelines, and it includes the protocols for feeding these newborn preterm infants, which is readily available. And everybody can look at it and see what is being done and what we can do more. It's just for centers to now adopt some of those guidelines. So for all of us, we must keep on to advocate reframe preterm nutrition as foundational medicine. Once we do this, we can be able to know that, oh, okay, this thing is very important, and all of us will be fighting so that the babies can get this medicine that is not very difficult to get and is not costly for the mother to provide. So what is the cost of inaction versus the investment in nutrition? So if we don't do anything and we are doing it as business as usual, or we put in more efforts and invest in this venture, what are the benefits? If we do it business as usual and we are not doing anything, we are giving poor nutrition to the baby, we will keep on having high rates of extrauterine growth restriction, and then we keep on having a lot of babies later, ex-preterm babies, who have one challenge or the other. They have neurodisability because of improper nutrition they have. And this will be compared to thriving infants with optimal brain development. You see them being geniuses, some of them doing all their full potential. They are having it if they had optimal nutrition. If they don't have good nutrition, they are likely to be prone to having recurrent infections, longer hospital stays, and they become future burden. And you will be looking for special education centers for them, and also they will be having a toll on the healthcare system later on in life. Okay, and this perpetuates the cycle of poor outcomes. Unlike if they had optimal nutrition, they build stronger immunity, they are likely to have shorter hospital stay, and you build a generation with greater potential and productivity. And later on in life, they become human capitals for the nation. And they're not the ones that will be draining the resources of the nation. They'll be one of the builders, okay? Just because you took care of them and fed them very well when they're born, newborns. So across Nigeria, we have the power, we have the science, and our tradition supports it. With unwavering commitment, we have the power to ensure that every preterm infant not only survives but thrives and reaches their full God-given potential. And we can ensure this by these three-pronged mandates: champion and protect the mother's milk ecosystem in every hospital, innovate and adapt fortification strategies using available tools and evidence, educate and empower families with practical, culturally sensitive knowledge. And if we can do all this, we will be sure that our babies are going to thrive. So in conclusion, for the preterm infants, every calorie, every gram of protein is a dose of neuroprotective growth-promoting medicine. Ensure that they get it. Achieving optimal nutrition requires a multidisciplinary crusade. Both the neonatologists, the nutritionists, the nurses, policymakers, and the mothers, everybody's hand must be on deck. Let us move from merely saving lives to building lives. Let us make optimal nutrition the non-negotiable foundation of neonatal care in Nigeria. The time to act is now. Play your own role, and then our babies are going to thrive. Before I close now, I want us to have these takeaways. we discuss nutrition as foundational medicine in preterm care. The first one we need to know is that human milk is non-negotiable. There is nothing that is better than the breast milk. It is pharmacologic therapy for the baby. Protecting, promoting, and providing it is our first priority. So we must do it. We must ensure that they get this human milk, they get the breast milk. Fortification is essential for preterm babies. Unfortified milk fails our smallest infants. Protein is the critical driver for brain growth and preventing disability. So, and we know that for these small babies, the protein in the human milk is not nearly enough for them, okay, for them to grow as they are supposed to grow. So we need fortification for them. Aggressive and early feeding is a strategy. Start trophic feeds early. We use the parenteral nutrition as a bridge by setting up dextrose for them and putting amino acids and all that. But we need to advance and then add our enteral nutrition, which is our breast milk, and increase it steadily to match in utero growth. Extrauterine growth restriction is a preventable scourge. It is not a norm, okay? In as much as so many of our babies do end up having extrauterine growth, but it is something that is preventable and we can prevent it. It is a key predictor of poor neurodevelopment. Preventing it must be our unit score quality metric. So we must check how many of our babies at discharge are within the normal growth range we want them to be. How many of them are having extrauterine growth restriction? You can check it and then put control measures in place, feed them very well, and then check again and see if there is improvement. And then you will be happy that you have achieved something. Collaboration is the only way forward. Clinicians, nurses, administrators, nutritionists, policymakers, we must all unite to build a nutritional NICU ecosystem in Nigeria. Our goal is to transform preterm survival into thriving. We just don't want them only to survive, we want them to thrive. Thank you very much for listening.
Oh, wow, that's beautiful. That's so amazing, Dr. Ezewa. I cannot thank you enough. The chairman of education committee was just telling me now that her network has been acting up. If not, she would have really wanted to thank you so much. But all of us, can we just go to our reaction icon and give her a lot of hearts? Can we give her a lot of hearts? Go to your reaction icon, click it and send a lot of hearts, a lot of hearts. Dr. Ezewa, this is how grateful we are. We're sending you lots of love, lots of hearts, and we're saying thank you so very much. Thank you so much. We really appreciate you.
Thank you.
I'm sorry, I know you're not feeling too well, but I know I dragged you into this. Don't worry, I'll make you, I owe you hot pepper soup. Don't worry, I owe you one. So thank you once again. Thank you so much. So please, if you have questions, kindly raise your hand, just like we've said. Dr. Zema will be taking only 3 questions, please, so that she can go and take care of herself. If you have questions, raise your hand now. You can also drop your question in the chat box. I already saw one question, and I would read that out to you. But if you want to answer, if you want to ask any question, kindly raise your hand and then you'll have the floor. Thank you very much. Okay, the first question says, okay, so what I would do is, Mama G, Dr. Njokwelu, are you still here? I would allow you to give a vote of thanks on behalf of the chairman of the education committee since she's not here, and then you can get to ask your question first. Mama G, are you here? Dr. Njokwelu, are you here? Okay, so the question is, what are examples of hydrolyzed powder? That's the question. One of the questions I have on the chat chat box says, what is an example of a hydrolyzed powder? I don't know if you mentioned that in the course of your presentation. Dr. Esen, are you there?
Okay, you want me to answer immediately? Okay.
Yes,
There
yes.
are some milk that are hydrolyzed protein. Okay, there are some formulas that are hydrolyzed protein. There are some that are done and they are specifically for fortification, but they're not in our country anyway. Okay, so it can be used for that. But there's some formula that are actually come and it will be labeled that they are hydrolyzed. Okay.
All right, thank you so much. So Dr. Doris Alaneme, you have the floor. Thank you. Dr. Doris Alaneme, can you unmute yourself and ask your question, ma?
Hello. Good evening, all.
Good
Good
evening, ma'am. We
evening,
can hear you.
Can you hear me? Thank you so much, Dr. Beatrice, for your wonderful lecture. I really enjoyed it, like I put there in my chat. I'll go straight to my question. Before I wrote this question down before you even answered it, where I wanted to ask, does breast milk content differ among mothers? So they actually gave one answer to it, that we are still expecting research finding that will support that. Because what we know in the academics is that the breast milk content does not really differ, but the volume can be affected if based on the maternal diet. So I don't know. We are still looking forward to a research finding that will clear this. Then my question is, we have been talking about preterm babies. What of low birth weight term babies? Do they actually need this kind of aggressive nutrition support too? Thank you.
Thank you very much. Okay, so let me also reiterate what I said before, that the breast milk differs from mother to mother, actually. The contents, they may be the same, but the amounts in each mother's milk may be different. And that's why when you analyze, you know which one is deficient in that mother's milk so that you can give targeted fortification. Okay, so like I said before, most of the breast milks that has been analyzed are in Caucasians or people living abroad. So we don't actually know, is the same one we are reading, is it the same, the content? If we take a breast milk from a Nigerian mother, does it have the same equal content? I mean, is it the calorie, is it the same as that of a Caucasian's own? And if you take the iron content, is it the same with that of a Caucasians? I know that when I was in the India, one of the fortification they do for their babies there is vitamin D, because they know that in their own country, a lot of their babies are deficient. I think their mothers too are low in vitamin D and calcium. So all babies, even 10 babies there, they supplement them with vitamin D. We haven't done that type of study in Nigeria to know all our babies. Are they deficient in any particular, is the breast milk deficient in any particular content, so that we can target that and fortify it. We are still waiting for researches on that. And what the content of breast milk, the value, I mean, if we do milligram per milligram for each content, is usually different for each mother. Some mother may have more higher value for one particular nutrient compared to the other, while it may be opposite for the second mother. So that's why the targeted nutrition is very important. You analyze first and know which of the contents is low, so that you can target that and fortify for that particular baby. Okay, then the second question was, anyway, sorry, what was the second question again? I forgot.
I was asking that what of low birth weight baby, or even very low
birth weight babies, they are part of the small babies. So once they are small babies, they are managed the same way. So a term baby who is small for gestational age, something was making that baby to be small for gestational age in utero. So when they come out also, you also need to manage them like the preterm baby. We've had a preterm low birth weight baby who 10 babies who are weighing 1,000 grams. You cannot treat them like 10 babies. You manage them as small babies, like those preterm babies. So you also follow similar protocol when you're managing them.
Thank you very much. Thank you very much.
Thank you.
All right, thank you, Dr. Ezenwa. Dr. Uchechi Cynthia Nwachukwu, your hand is up. Can we have your question now?
Good evening, dear dietitians. Good evening, Dr. Ezenwa. Thank you so much for that wonderful presentation, ma. Yeah. Please, mine is more of clarification because I have interest in this pediatrics. One, when I did my research in my PhD research, part of it was in IUGR assessment of the prevalence in the selected states. And I got to know that male neonates, preterm or low birth weight, die more than the females. And the clinicians I asked couldn't provide a clearer answer. They said that women withstand stress more than men. I would like to know, is there anything that has been found out recently that's why men die more than the female counterpart? That's number one, ma. Two, these children are not only trying to be made to survive, but also to thrive. What are the hospitals doing after they have been discharged? Are they and their mothers referred to the dietitians for continued management? Three, how do we create a mother critical centered lactation ecosystem? Do we think of the dietitian because is that the office of the dietitians that they have enough time to get all the counsels that they need? Are the dietitians at the center? I know the doctors, that the pediatricians and the nurses are there, but with the help of the dietitian, this lactation ecosystem can well be established where the mothers will pour out their hearts to the dietitians for better counseling. Ma, I would also like to know, these fortifiers
Sorry, Uchechi, please. I mean, you're already giving like four, you're already taking like four questions, and we also still have another section to go by. Can let her answer this one so that other people can also get an
sorry, ma, let
opportunity.
me ask
You already asked three questions. Please let her just answer them. Thank you. Go ahead, Doctor.
Can I drop it on the platform?
Yes, please drop it on the platform. I'll get an answer for her. Thank you.
Okay, so let me start with why do male babies die more than female babies? Okay, preterm babies. It's not just the preterm. And the research you did that pointed that some other researchers have also found out that, and the answer they gave to you will be one of them, that females withstand stress more than male. The other one, there's actually, what is it? Some people believe it may be in the genetics, in the makeup of the females. Some believe that the double X chromosome confers stronger immunity to the to the female child. You know, men have only one X, and if the immunity is being conferred by the X chromosome, the female have double X. So they are stronger than the male when it comes to immunity. Okay. However, those are projections from people. We haven't been able to incontrovertibly defended that. Okay, but that is some of the projections that people gave, the suggestion they gave, that's why a lot of the male babies die more than the female babies. Then coming to the follow-up of preterm babies, yeah, preterm babies, when you're discharging them, one of the standard of care is that you should follow them up. And when you are noticing that before you even discharge them, your nutrition guidance should be part of it. You must be able to explain to the mother how to feed the child, and these babies are being followed up. You keep on monitoring them. Once you notice challenge, like I said before, is a multidisciplinary approach. I have had cause to send some of our mothers to the dietitian so that they will do the nutritional counseling, be able to help in fortification and all that. Okay, so it's not a one man that will do it all. When you notice challenge, everybody should, all hands should be on deck. The ones you can do, you do. The ones that the dietitian will help to do, they also do that. It's for you to know, have a protocol and know that, okay, this thing is available. This person can be able to help out here. And then you do. Some of our mothers have gone and they do feeding demonstration and even food demonstration, especially by the time these babies are reaching 6 months and they need to go on family diets and all that, complementary feeds. You see them most of the time. The dietitians are also part of that management. If we think the mother is not coping, they usually go for training and they do sessions with the dietitian on how to help that child to feed, what to feed, what quantity to give, and all that. And of course, you keep on monitoring, because these babies, you don't send them home and forget them. You must be following up on them. How do you make the the NICU to have an ecosystem of this mother-baby breastfeeding circuit that we are talking about? Okay, so that is something that everybody has to be conscious about. So in each facility, you have the dietitian, you have the pediatrician, the neonatologist, and the nurses. So everybody comes into contact. Collaborate. Okay, I have had challenges of my babies in my unit that are not growing. Every time you come, what is the weight? They are static, they are not growing. And then you ask how much milk have they getting? They are at full feed, but the child is not gaining any weight. We had to call our dietitians, please come on, let's see, what are we going to do? Is it that the mother's milk doesn't have much nutrients? How do we fortify and all that? And then you call the dietitian and they will come, because feeding the babies is not as easy as you want to feed them. You don't want to give too much fluid, but you want to give high calorie content. So the dietitian comes and tell you, okay, so you want to give only 100 meals. And in that 100 meals, you need, like, if you needed a quantity of 200 mils of breast milk to give you what the calorie you want, the dietitian will come and tell you, okay, because you cannot give more than 100 mils, this is the amount of fortifier we are going to put in the milk, so that it will bring up the calorie content of it. So most dietitians, they work hand in hand, okay, in our unit. The only thing is that because in neonatology is majorly breast milk we are using, that's why you are not seeing a lot of that interaction. But once you have a baby who is not thriving, who is not gaining weight as is supposed, the dietitian, they do come into play. They come to help in the management of that child, because we all have to put head together, knowing that you have to weigh between high volume and high calorie. You want to moderate the volume you're giving, because if you give too much, you cause more problem for the child. And if you're not giving enough, the child is not going to grow. So everybody's hand is on deck. So if your own facility is not involving the dietitian, after this webinar, I think we should have a rethink, talk to them. I'm sure they are waiting for somebody to mention it to them so that we all come on board. Thank you.
All right, thank you so very much. So, Daishan Ubong, please, one question. You'll be the last question we'll take for this session. Thank you.
It's okay. Thank you, man. Good evening,
Thank
everyone.
you, hands, please.
Thank you, Dr. Beatrice, for that wonderful presentation.
Good
Please,
evening.
my question is simply, I've been, before now, known preterm babies to be babies born before 38 weeks of a gestation. But in this your presentation, I've heard you mention a baby born less than 28 weeks. And you've also made criteria for the nutrition guidelines to be based on kg, body weight, and the rest of it. So my question is, apart from using the kg body weight, are there other things that can be considered based on the weeks of gestation? Since you've mentioned babies born less than 28 weeks, are there other things we may consider based on the weeks of gestation? That's my question.
Okay. Preterm baby is any baby that is born less than 37 completed weeks of gestation. So if that pregnancy doesn't last up to 37 weeks complete, it means that baby is a preterm. So, but in preterm, we have grades of prematurity. Okay, the preterm who is born at 34 weeks until 36 weeks, 6 days, is called a late preterm. Okay, that baby is more mature compared to a baby who is born below 34 weeks. Okay, and a baby who is born between 32 weeks and less than 34 weeks is said to be moderate preterm. So that one is also more mature compared to a baby who is born below 32 weeks. Okay, between 28 weeks and 32 and before 32 weeks is said to be very preterm. And then we have the extreme preterm babies, those who are born less than 28 weeks. So all these gestational ages actually have a bearing in the way you manage them, because the complications you see in them differ. And so the smaller the gestational age, the more complications they have, and the lesser the survival you are going to get, because they are smaller, they're going to be smaller in weight. So for preterm babies, you can either use the gestational age to classify them, or you can use their weight to also classify them. Okay, you will hear us say, talking about the low birth weight. Low birth weight is any baby whose weight at birth is less than 2.5 kg. So any baby who is weighing less than 2,500 grams at birth is said to be low birth weight. But among that low birth weight, we have categories. We have just those who are just low birth weight, meaning that they're about from 1,500 grams to less than 2,500 grams. We have the very low birth weight. These are babies who are 1,000 grams to less than 1,500 grams. And then we have the extreme low birth weight babies who are less than 1,000 grams at birth. And the smaller they are, the more the challenges. And their challenges are many. Challenges can be from the respiratory problem they are going to have, which is the first one that they are faced with. Their lungs are immature. So once they survive that one, you talk about the nutritional challenge they're having, and every infection, there are challenges they're having, and every other thing. So the preterm baby has a lot of challenges. It depends on which one you're looking, which direction you're looking at that particular time. For this lecture, we are looking at their nutritional challenge. Thank you. I hope we answered that question.
Yes, ma'am. Yes, ma'am. I got the point on, especially the complication. Thank you for that session.
Thank you.
All right, thank you, everybody. Thank you. So you can also go through the chat boxes and look at other people's contribution and all of that. So somebody had talked about how a study was done, and we found out that a particular mother had good store of fatty acids and all of that. So there are studies coming up on that, and one of the essence of these webinars is actually even to actually even help education committee to begin to channel to areas of research, and then discuss with internship facilities and see how we can come up with some of this research and come up with a proposition on our findings. So this is actually the essence of this webinar and all of that. So once again, on behalf of behalf of the Education Committee of the Dietitian Association of Nigeria, on behalf of the sponsors, we want to say a very big thank you to you, Dr. Exenwa. We really appreciate, I mean, we're all so glad for this lots loaded information that you've given to all of us. We're so grateful. We don't take it for granted, but then we thank you for your time and we'll pray for your speedy recovery and you get well soon because we've taken time from your rest. Thank you so much for being here. So you can take your
Thank
leave now
you.
so you can rest. I would send
Thank
other
you
questions
very
to
much.
you if
Okay.
then yes, thank you.
Thank you very much once again for
So please
giving
let's
me
clap
this
for her again.
opportunity.
Let's
Thank you. Thank you, the
hit the
Committee on
clap
Education,
reaction.
for giving me this opportunity. Thank you very much. And help me greet Dr. Chikandi Okwelu. I thought she was here, but I
She
didn't
will
see her.
hear.
Okay.
Yeah, she was here. She
Thank
was
you.
here. Yes, she was. Thank
Thank
you
you.
so much. We really
Thank you very
appreciate it.
much,
God bless you, ma'am. Thank you.
Patience. Thank you.
Thank you. All right.
Bye-bye, everyone. Thank you
Bye,
for all
ma.
the love messages. I saw them.
Bye,
Thank
ma.
you.
Bye. Thank you so
Bye-bye.
much. God
Thank
bless you,
you.
ma.
Thank you, ma. We love you.
Very
Thank
good.
God bless you,
you.
ma. We are grateful, ma.
We
Thank you
hope
so
to meet
much.
We are very
again.
grateful.
Thank you
Thank you,
very much.
ma. Love
All right.
you.
Thank
So
you. And
thank you so much. She has heard, and I'm going to tell her more. So not to waste much of our time because this was supposed to be a double presentation. Hello, can we mute our mics, please? We're not done yet, please. Okay, so like I said, I'm going to throw more light on the areas of the fortification because I know that that is where a lot of us have challenges. I've seen a lot of questions on fortifiers. So one of the questions about the fortifier is it the same thing as infant formulas? And I replied to someone, I said, no, the fortifiers are a product on their own and they are tailored to be used only for breast milk. So maybe what I could do is I'll get a picture of what a standard fortifier and share with us on the platform. It comes in powder. So what you basically want to do is to increase the calorie density of the breast milk without increasing the volume. So if you had remembered what she has said, you look at the fact that there's also fluid, there's an amount of fluid that every child that neonate is supposed to have a preterm. So you can't just, it's not normal fluid like every other term baby. So fluid is calculated, calories are calculated, proteins are calculated, and fat, minerals, all of them are calculated for that person for a particular preterm. So now, when you get the fortifier, it comes in it comes in like a paper, and then you put it. So there are calculations to it, and sometimes it will tell you that you can only add it to a particular amount of breast milk. So if some will say you can only add it to 100 ml of breast milk, you can add it to 50 ml, depending on the prescription on the fortifier. So when you do that, so it now depends on the amount of feed that child is allowed. So at that point in time, you could do that and you store it and then you spread the feed across. So if the preterm is taking only 20 meals per feed and the child is feeding 3 hourly, so that's like 8 feed. So you can't give all of that 100 meals. All you need to do is take out, reconstitute it, the breast milk and the fortifier, take out the 20 mils of the fortified EBM, yes, express breast milk, and then you keep the remaining and spread it throughout the day to meet up the need of the child. So that's one. Now, to the other parts of the tier 2 fortification, where she mentioned MCT oil. The truth of the matter is, I think it's something we really need to appreciate. And at this point in time, I think we need to give a lot of kudos to the dietitians in Lagos University Teaching Hospital. We have an environment where there's a lot of respect for dietitian. We have created an environment where we've been valued. We have given value. We have given value for a lot of things, and then we have bought our space. So we didn't just get the value. It isn't a gift. It wasn't a reward. It was something fought for, and we only bought it with result, outcome, and respect. So we don't just supply MCT oil, we calibrate how much of the MCT oil that needs to be added to each feed. So it is pure dietetics, and it's not something the doctors will just wake up and use. They have to involve the dietitian. So we're not just supplying MCT oil. No, we came up with the fortification with MCT oil. It was something the department came up with. It was something the department started producing by themselves, and it's been a win-win. And I can tell you confidently, it's been spread across the entire Lagos state. It's been spread outside of Lagos state. So many persons are using it. We have a lot of pediatricians, neonatologists reaching out to us. Oh, how do we do this? How do we do that? And then because LUT is a fertile training ground, even pediatricians who come to train in LUT go with this information, and they still reach out to us to continue from where they are. So we do not just supply, we calibrate, we calculate, and we decide how much we'll be giving at each feed. So that is where our involvement is. There's another type of fortification that we started also by the dietetic department of LUT. We started what we call the EBM and BMS fortification. Now, I want to categorically put it here that we have what we call the preterm formula. Yes, it's different from the fortifier, like I had said before. And remember, she had said something about the amount of protein that this preterm formula or the feed, either breast milk or the amount of protein that the breast that the child requires. So it means that the child requires about 3. So the target is about 3. Some literatures will tell you 3 to 3.5. Some will tell you 3 to 4 grams of protein. Some will tell you per 100 ml or per kg. So, but the truth is that, of course, the breast milk cannot produce this amount. But then, of course, there are some formulas that can also produce it. So we need to be very careful what we do and how we use them. So, but then I also know that, I mean, some formulas like we've used can confidently give you this amount of protein. An example is Nutriprem after meal. So it can give you this particular amount, and then but it means that in what quantity. So the quantity comes in very well. So I want to also explain to us that the preterm formula is way different from the term formula. So what are the difference? We have you have the preterm, while you have for term babies, you have the formula 1, 2 based on age. You have 0 to 6 months, you have 6 months to 12 months. So term formulas are not the one you use for preterm babies. There are preterm formulas, and they have higher calories than term formulas. A preterm formula has about 80 kilocalorie per 100 ml, while a normal formula, a term formula, will give you about 67 kilocalories per 100 ml, which is what your breast milk will give to you. So the formulas are tailored to mimic the breast milk. But in all of this story, what we need to go home with is, no matter what we do, breast milk remains the best. So mothers are encouraged, either through pumping, either through electric pump or expression, to produce breast milk. And like she has rightly said, that breast milk is not enough for a preterm baby. So fortification comes in, and then fortification can be either through the fortifier or through the MCT oil. Some also use soya oil, but one of the reasons we do MCT oil, we can all go and read up, is the ability. Remember that they have immature organs. The preterm have immature organs. Their livers are not matured. So, but for medium chain triglyceride, it is easily absorbed and do not really go through digestions. We can look at that, which is why even the preterm formula has a particular amount of medium chain triglyceride they use in that formula. So it is something that is very, very common in the preterm formulas. Now, she talked about hydrolyzed hydrolyzed powder. There are some formulas that actually come with hydrolyzed protein. Now, there are 2 types of protein. You have the hydrolyzed protein and you have the intact protein. So some researches are ongoing. If is there any difference or benefit between hydrolyzed and all of that, but when you talk about hydrolyzed, it means it's been further broken down, and then because it's been further broken down, it's easier for the child to absorb. So we've been on a long journey when it comes to the in the neonatal world. We've come a long way. In fact, myself and Dr. Ezenwa, we've actually managed, the first time we met, we managed a 700-gram baby and an 850-gram baby. So it's been a beautiful journey. Pediatrics is beautiful. Neonatal nutrition is massive, but it's something that you need to be passionate about. And remember, children don't talk, babies don't talk. So you would be the one to do your research and do the needful and help the pediatrician achieve the growth and necessary weight gain for the child. So that's where the dietitians are champions. But then again, this is also a clarion call to other centers, to other facilities who do not really do much of pediatrics. I know pediatrics is an aspect of dietetics that is growing, but then even though there are no specialization in quote, you can enhance your interest in pediatrics, and this is one of it. So the education committee has decided to roll out things like this to help people enhance their knowledge and kind of tickle your interest in some certain aspects of dietetics. So pediatrics is very beautiful. It's, take it from me, it is very let me put it, very challenging, because you want to achieve something and you have to do it with the limited volume that you have. And so also to add to what Ubongi, your question, you also have situations where you have 10 babies that are either low birth weight or underweight, either because of a secondary, that low birth weight or underweight comes as a result of a secondary problem. So they are not underweight because they were not born well, but maybe they have hole in the heart, congenital heart diseases and all of that, that is making them have failure to thrive, or they are not able to do that. And so fortification also come in. So like I mentioned before, another type of fortification is the breast milk and the BMS fortification. We have also succeeded in using it in Luth, and I tell you, it's been successful, but it's something that was actually studied for a long time. So if you try to read up literatures, you will see where they'll tell you, okay, you can do 70-30% of fortification, you could do 60-40%, depending on the percentage rate that you want to do. So it means 70% of breast milk and 30% of a preterm formula or powder, so, or 60% and 40%. So it's a whole lot. But what I'm trying to say in essence is that it is doable. We've been doing it, and it's what we can still do. So I want to tickle all of us to begin to look at the area of pediatric dietetics and to help our institution, because you cannot give what you do not have. You can only give what you have. And if you have done something and there is result, everybody will just leave you for it. And then there are some questions around lactose intolerance and all of that. And if of course the breast milk contains lactose, so if the child, even before you get to the fortifier, if the child is lactose intolerant, of course there will be some issues, and there are some investigations that will be done to establish that, and an alternative source is given. And that's why we have what we call isomil. It's actually a formula for lactose intolerance, and there are some formulas that are actually made and built for lactose intolerance, and then some formulas are actually lactose free at about 90 something percent. I know Aptamil has some of those products. Unfortunately, some of those products are not in Nigeria, but we can actually do what we can. We can still find them in parallel market, but I know that they exist. So this is also a clarion call to reach out to us. In Lagos University Teaching Hospital, I know a lot of my colleagues are on here, and then I really want to thank them for their support and what we've achieved and what we've done. You can always reach out to us. We can always assist you if you're trying to raise up a unit, pediatric dietetic unit in your facility, and help with newborns and the neonates and preterms. We're always open. So I don't know if you have questions about that before we close, because I'm sure we've taken much of your time already. Any questions on the fortification?
Hello. My hand is up, please, Chief.
You should have put this hand down since you left it up since the time you asked question.
I put
So,
it down and I just raised it. I just raised it now, ma.
okay, please go ahead. Just one question, Uchechi, so that others can ask their own.
My own is a contribution. I
Your
want
own
to
is
thank I want to thank the Education Committee and the Youth Dietitians for bringing this up. Because if you could remember last year, when I raised a concern during my research, the neonatologist asked me if I think it's their duty to feed this neonate. That is the duty of the dietitians. Now, thank God this is coming after a year plus. Ma, please, I want to plead that the dietitians in the different units that have interest can form a WhatsApp group where it will be chaired by the dietitians from those who have been doing this. Because the neonatologists in my center complained that they tried giving the dietitians some cases to manage and they nearly mismanaged. I told her it's just a little training that will put it. Please, I want to see that the dietitians in Luth set up a WhatsApp group and add all the dietitians from the different units who are interested so that they can give them a training. Will I say a step down training how to manage this neonate? Thank you, ma.
all right. Please, can you put your hand down so I don't keep calling you up?
I
Okay,
just
any
raised
other
it.
question? Okay, any other person? Any other question? Can I see your hands up? Can you raise your hand? Uchechi, your hand is still on. That's why I'm calling you. Who else? Who else? Any more question? Awele Johnson. Okay, go ahead, please. Thank you.
Okay, ma. Actually, just wanted you to throw more light on calculating the calories for neonates because Daishanu Bong was actually asking that. That was he was asking Dr. Izenwa that do they calculate per kg body weight or based on their prematurity? Is there any other standard they can use to calculate their calorie? And also, when we went for and meeting at last suit, I found out that they were using the normal calculation for 10 babies to calculate. They actually managed a preterm baby as a term baby because they were using the same calorie and giving a preterm baby about 700 or something calorie. So I think it's something we should throw more light on since Daisha Nubong had asked that question, but Dr. Izenwa did not answer it.
Okay, thank you, Johnson. The thing is, it's not like she did not answer, but I know I understand where she's coming from. So there are two questions there. If you can have a 10 baby and that baby is low birth weight. We've had 10 babies that got through gestational age of 38 weeks, 40 weeks, and were born full 10 babies, and they have low weight. So that is the difference between a preterm and a low birth weight. So now, if you have that scenario, it now depends on it depends on the scenario you have in your hand. And then, which is why she also went ahead to explain the different categories of birth weight for preterms. You have the extremely low birth weight, you also have the low birth weight, and then, of course, you have the preterm. And then that has to do with the gestational age, if you ask me, the weeks, and all of that. So the thing is, if you have a term baby that is low birth weight, of course, you're not going to manage that child as a term baby. So what happens now? So that's where the difference between chronological age and biological age comes in. So what are you looking at? So even for these term babies, remember, and for this preterm, when you also look at them, when you even want to calculate, you need to even equate those 28 weeks at that moment. You have to equate that age to, so it's not just the weight, the age at which the child was born when you are managing. So that determines, okay, this child has been alive for like 3 weeks or 4 weeks, but he was born at 28 weeks. So this 28 weeks plus that 4 weeks, what is it supposed to be? It's just like 32 weeks. So you're looking at that child as at that. So if it is a 10 baby that was born of low birth weight, remember what we talk about for low term for 10 baby, low birth weight is anything less than 2.5. So if it is low that way, you're going to manage that child as a low birth weight, regardless of the fact that the child was born as a 10 baby. So she cannot categorically give you a figure because there are different scenarios. So what is important is identifying and establishing where that child falls into. And for the calculation you're talking about, well, let me apologize for that. I don't know anything about that, but that's very wrong. So you do not use the calculation for term babies for preterm. Remember, so why is it a little bit tacky to do kg? What if the baby is 800 weeks, 800 gram? What if it's a 900 gram? So it's not even up to a kg. So some literatures will tell you per 100 meals, and these calculations are based on the weight of the child, of the baby. So the amount of fluid is based on that. So it will determine the amount of calories based on the amount of volume you have. So it's not something we're going to exhaust here. If there's going to be a training, fine, we can do a training where the calculations will be done, but it's not just something you answer like that. So it needs to be really looked into the exact scenario established, and then you cannot take in your management. Thank you. I hope I've answered your question. Patrick, I have your hand up. Thank you. Can you ask your question now?
Can you hear me very well?
Yes.
Hello.
Hello, Patrick. I can hear you.
Okay, so mine is basically a contribution to the
Okay.
whole discussion today. So the first thing I want to add to is regarding what Dachan Uchechi mentioned earlier about having a WhatsApp group. I think we should be thinking in the line of having a practice group
Yeah.
for those that want to go into pediatrics. And there
Okay.
is something some professional bodies usually do. They do specialist mapping, whereby they can do a survey where members can align to a particular specialty. So we can do that within dietitian profession so that we can have people that go into different specialties. So within those specialties, they can have their practice group where they can meet periodically to develop themselves, new information, like for instance, if there are centers that need to upgrade their management of pediatric cases, so that can be done within that practice group. That is my first contribution. Then
All right.
regarding
Thank you. Okay. You have another
yes,
one.
yes, regarding the comments that were made earlier and the question Bon asked, if you listen to the presentation very well, the presenter gave grace of prematurity in terms of weeks or age of birth. So regarding the equation she gave, though it may not be correct, I have seen that most of current equations use gram, not kg, because most preterm babies are usually, I've seen 500 grams. So most equations usually start from, is usually in grams. And again, remember from what she gave, it was a range. It was not static. She said something like 3.5 to 4.5. So if you now equate it to the age of birth, for instance, if someone that is at the lowest end of less than 33 weeks, you can start with the upper range of that requirement. For instance, if it's energy, you can start from the upper range. As the age of maturity is higher, you can start from the lower age, depending on other conditions that may be assessed during that can be assessed during the management. So that is the contribution I want to make to the presentation. Thank you everyone for
All
coming
right,
along with
thank you,
this.
Patrick. That's absolutely beautiful. You're very correct. Like I said, there are ranges. Like I said, some literatures will tell you three to four. Some will say 3 to 3.5, three. So basically, it's 3 to 4 gram, basically. So, but which is why I was saying that for that Ubong's question, what if you have a situation whereby, or when you're saying kg, what if the baby is not up to a kg? So those are we see a lot of 700 gram, 800 gram, 900 gram, 1000 gram babies. So sometimes, or some other literatures will also tell you per 100 meal. So some
Yes.
literatures tell you you require about 3 to about 4 gram protein per 100 meal. So like I said, it's if you have if the baby is up to a kg, and then of course when they are terribly so small, of course you'll be considering parenteral
Parental,
nutrition.
yeah.
Yes, because during parenteral nutrition, because of the fragility or the immaturity of their organs. Thank you so much, Patrick. Yes, it is called practice group. Basically, it's called the practice group. So, like I said, the essence of this webinar is actually to begin to tickle our interest to a different specialization. We might not have one, but I know we're going to get there. We're going to get there, but then we're also beginning to have some collaborations that we hope to work out very soon. So people with genuine interest, and then you cannot. And I want to appeal to our dietitian. See, the essence of the WhatsApp group, and I want to appeal to everyone, is not to berate anyone. If anybody asks question on something, don't look down on that question. Whoever has an answer to that question can help at that moment. So it's also a call. I want to appeal to encourage everybody, whatever difficulty you're having in your practice, especially when you're managing a patient, you can post it on the platform, and those who have the expertise, can actually help out. I know a couple of times such information, some things come up like that, but then instead of mismanaging a patient, just like the scenario, so the last person just painted about how they managed the preterm and they were using the calculations for 10 babies. So instead of us having that, and then just like Uchechi said, the doctor said, oh, they almost killed our patients. Reach out to those who have better experience. In Lutz, I can categorically tell you that we're beginning to have almost like 20 years experience in managing neonates. So it's a whole lot. So tap into the resources that the association provide for you by speaking to those who have these specialties and then who have practiced it. You might not have the degree or title to say, oh, pediatric dietitian, but I bet you we have the expertise, and then definitely we can help anybody and anyone who requires our help. Dr. Doris, I would like to take your question, but this is going to be the last question for the day. So let's quickly have your question, ma. Thank you, ma.
Thank you very much, Matt, for this wonderful opportunity. I really appreciate everyone. Please, my own is like Jake's contribution. What I wanted from the academic section here, we see most of these students that when they come back from IT, they have different opinions. They have exposure. So I'm just asking if there will be a way, maybe from Dan, that there will be protocol. Like the last presenter talked a lot about protocol. For most of these practices, let there be protocol coming from Dan, so that when students go for IT, they go to different teaching hospitals, they don't come back being more confused than when before they go for IT. So if at the end of the day, most of these common diet-related diseases that we know that most of you in practice, that you are having them, and you have, maybe there should be a protocol of the hospital will have practice the same thing, they will manage the same way, so that students, when they come back, they are no more confused, will be on the same page. Thank you very much.
All right, thank you so much, Ma. Yeah, I think I totally agree with you, and I think it's something the education committee is going to look into. But then again, coming from a center, a training center, I also think that we should actually be able to come up with a protocol for IT students, because for IT students, there should be a limit to what they're exposed to, like you said, so that they don't come back confused. But thank God now that the practice is now the curriculum is now tending to 5 years, and they have more time for hospital practice. So maybe when they come, then they have better understanding of dietetics, and they can actually see the patient, see how the management is done, and they can see the outcome, and so they are not confused. So, but at that point, I think we need to also come up with protocols. And we have a unified protocol for all centers that manage IT students. What are they expected to see? What are they expected to learn? So that they don't become more confused. In my center, we try to manage what they're exposed to, because you have people that have not even learned the rudiments, the background of dietetics, and you're opening them to some clinical management. Of course, they'll be more confused than when they came. So this is an assignment we need to come up with a protocol to what they are allowed, where they are supposed to go to. If they're going to go to ward what exactly should they see? Because talking about natal, in fact, there are some areas in the hospital that even interns are not allowed to enter, say the list of IT. In my center, in ICU, even medical officers don't go to ICU. The only residents and consultants. And the same thing with NICU. So really, they don't have any business there, really. So they will only come back more confused than they were. So I think this is something we need to establish and then make sure that, we fine tune and then we do the needful. So
Okay. Now they
is there
have
any more?
6 months. No, they have 6 months. So they have
Yes, so that will give them more
postgraduate
room.
level.
Yes, yes.
Yeah.
All right,
Thank
so
you.
I want to use this opportunity to sincerely thank everyone. I want to thank our diasporal dietitians. Patrick, you're the best. You've always been there for us. You always show up. I saw the national vice president too, Tolu Lokpe from Canada. Thank you so much. I really appreciate your presence. It's actually giving us the boost to go on. I want to appreciate everybody that has been here, that have taken your time, your data, and everything. I want to thank those that have contributed. And on behalf of the education committee members, I saw a lot of them here. I'm also very impressed. I want to thank you all for the support. I want to thank our sponsors because really it's not been easy to pull this out. The timing, the personnel, our sponsors got us the personnel to talk about what we need to talk about. And then we want to believe that we will continue doing this from education committee to whatever things we are beginning to look at, so we look at them. But I want to encourage every member to please plan to attend the conference. It's always very important because when we talk about practice group, nothing will stop us in a conference to decide to say, oh, the pediatrics practice group will be having this particular thing. It could be their own, workshop, it could be their own sub workshop they can have even during the conferences. So we can only grow when we attend conferences and help our profession. It's our own. We must do everything. For the past how many years I can remember, I don't think I've ever missed any conference. Even before I became an ESCO or education committee member, I planned myself for every year. I begin to save. Everybody knows me for that. I save money for conference because I take it as my own mini vacation from work, vacation, and I enjoy myself. I listen to all I have learned mostly in dietetics has been from workshops, from conferences. The NCP, I learned it from conferences, from workshops. So we can only improve ourselves and update our skills if we attend conferences. I mean, it's so sad when you get reports from people. I've gotten reports from centers where doctors complain about dietitians. They're still doing the old thing. We're not moving. We're so obsolete. We're so backdated. We're not doing anything to improve ourselves. So we also need to read. So most times, a lot of people want to be like the doctors. Are you able to go through what they go through? Can you sacrifice your time, your energy? They pay for update courses. How many of us would have been willing to pay for this course if a price tag has been attached to it? So we must learn to upgrade ourselves. We must learn to improve ourselves, and we must learn to improve our skills. Really, if we need to make impact, I won't tell you lies. It did not come on a safe. It did not come on a safe plate for dietitians in Luth. We faced a lot of panels. Can you explain this? Can you explain that? But the only thing that spoke for us was outcome, was results. So the results were compelling. I remember this Dr. Eze when we managed the 700 chair. That was where the God blessed us with the wisdom of MCT oil. So it's just, and it worked out. And then I know other consultants that have keyed into this and they are doing well, and they will call us from their centers and they would ask us to help out, and we're always willing to help. So I want to really use this opportunity to thank the pediatric dietitians in Luth. We are the most worked, we are the most we most stressed, we're the most. And you come to ask anybody of dietetics, pediatrics in dietetics in Luth, once you come there, you're going to work your ass out. So the truth of the matter is that we must be willing to give so much for our profession. We must be passionate about it and not just looking at money. Money is not about everything. It's about results and outcomes. And I believe that going forward and following this, like I said, maybe the next by the time we'll have a meeting with the centers and we'll decide what the researches will be on. if centers begin to say, okay, our interns, you look at this, taking about some mothers, we say, Ebonyi, give us the nutritional composition of the breast milk of the mothers in Ebonyi State. We have that from Lagos, we have from Enugu, we have from the north. At the end of the year, we have reports of Nigeria, and it can be published. So like Dr. Zanwa said, it is a multidisciplinary thing. Nobody can do it all. And then recently, we also partnered with the Pediatric Association of Nigeria to see how we can break through and do some things when it comes to pediatrics. So we're not lying low. We're doing everything we can, but then we want to encourage every member to reach out, to put it on. Let's not make the platform where we come to do other funny things. Let it be a place where we can learn. People can ask questions without being mocked, without being laughed at. And then when people drop their question there, if you don't have an answer, don't go back to DM them and to tell them nonsense. I've gotten such reports. So when you drop your questions there, please, if you have an answer, answer. And then usually it becomes a way of debate where we talk, where we rub minds, not for anybody to gain any attention, but to help whoever needs that. So I think that going forward, we will do the needful. I want to thank everybody. Even after 2 hours, we still have like 70 something members. Thank you so much for your time, and God bless you. Thank you. Thank you. On behalf of the president, of the chairman of the education committee, Ma, are you here now? Professor Nzagu, are you connected now? I know we lost you at a time. Are you here now?
Connecting and the thing living again.
All right, thank
Thank you
God
so
you're
much.
back. Yes, Ma.
Thank you so much.
Final
We
vote.
really appreciate you and appreciate Dr. Zemwa. It's been a wonderful time, very educative, very insightful. And then I think many of us, a lot of things are getting agitated in our hearts on the way forward. And I believe that going forward will make more impact wherever we are. And I think I want to buttress the fact of the group, the different areas, yes,
Yeah.
the different areas of interest, so that we can start. And I think maybe by the time we come for the next conference, we may really break out into sessions.
Exactly.
Where people from different that have interest in different groups will organize themselves and then start thinking of what to do to help each other, especially those of you in the different facilities, helping those of us that are not there. And then we also bring in from our own experience in the classrooms and researches to see how we can move forward. I think this is a good way forward. And I believe that we'll be having more of it in the next year. Thank you so much.
Thank
And I
you
want to
very much.
thank everybody that has been available for this webinar. Having said that, I think we can now call it a day, except there is any other pressing thing. Thank you so much, Gratitude Past.
Thank you, Ma. Thank you for allowing these workouts. I mean, your leadership has been very impactful. We love you. God bless you so much, Ma. All right, thank you, everybody. It's been a wonderful time. Have a wonderful night's rest, and God bless everybody. Thank you so much.
Thank you, Ma.